Get started if I remember it. Cool. So my topic was on perioperative management of patients with diagnosed obstructive sleep apnea. So this is patients specifically that have already an established diagnosis in the perioperative setting. So one of the things that I'll be kind of sprinkling throughout the presentation is a lot of just different like guidelines and um, you know different pieces of evidence that were kind of discussed with all of these different journals and societies, and it does make it a little bit of a kind of complicated hodgepodge of different pieces of information because every society has their own little specific preferences on how things should be done. But yeah, we can start right here. Everyone kind of knows what obstructive sleep apnea is, or OSA. It's just where there's an obstruction of some kind of when the soft palate relaxes too much, causing the airway to narrow, close, leading to episodes of non-breathing with different varying degrees of oxygen desaturation, causing a lot of different problems. We know this from like a medical student standpoint, where OSA chronically can cause or at least contribute to so many different significant health problems, like you see here, like hypertension, heart disease, um, you know, lots of different problems that treating OSA early and efficiently can help reduce some of these problems that these patients are having, especially in the perioperative setting where some of these specific comorbidities become an increased risk factor. But one interesting fact I thought was funny about the prevalence of OSA is that it's actually estimated to be between 6 and 17% of the general population, and 68 to 70% of those high risk populations, such as those patients undergoing things like bariatric surgeries or major non-cardiac surgeries. So it can be a very, very big portion of the population, whether it's known or not beforehand. Perfect. So some of the perioperative complications that come with patients who have OSA can vary pretty significantly. But it's important to know, and it's important to know when you're someone involved in the perioperative care of a patient, that someone with OSA, especially if you know it ahead of time, they do carry about a 2 to 4 times higher risk for complications than an average person. So some of those risk factors that contribute to potential higher risk of complications is the type of surgery. Obviously, if it's like more of a major surgery, anything that will potentially further exacerbate an airway obstruction that someone already previously has. A lot of those, and we'll get into those later, but a lot of those do come in the form of like medications and anesthesia and all that. But the severity of the OSA is obviously really important as well, because if someone has obviously a worse case of OSA, they're going to carry a higher risk. Also, length of treatment. So, when a patient is in the OR, how long are they going to be under for a procedure? How long are they going to be given medications that are going to potentially cause further airway collapse? Other things to consider are the need for post-operative opioids, which I will talk in more detail later, and then the additional OSA related comorbidities. So a lot of those things that I mentioned before, the essentially like the more of those that you have, we know that in just a higher risk population, those all they're doing is just amplifying the risk factors for potential complications. Some of the other complications that the two biggest ones that I did want to have like their own focus on is the respiratory complications and the cardiovascular complications. Those are just some examples there, but those will have their own slides, so I don't want to like take up too much time and repeat myself. But other reported events which are significantly lower, but there are definitely like case reports out there you can read. You can see them on Up to Date where they do pop up, and those are things like acute renal failure, hematomas, seromas, ICU transfers, increased length of stay in the hospital, different types of delirium. We'll see other things like REM rebound and stuff as well. And then obviously mortality. This one is where a lot of different societies and journals debate, and there's just not great evidence on this. But there is some kind of association with obviously the greater the risk factors that a patient has, the higher likelihood, obviously, that mortality can happen. So the first one here is the respiratory complications. So, I mean, we've all studied this so much. So to us, it's not like rocket science to think that when a person has recurrent hypoxic events, over and over with like a patient with OSA, especially in the setting of an OR or even in a perioperative setting, if they're just not getting oxygen, you are just significantly causing more problems, right? Especially when these are patients who need to be circulating oxygen throughout their body, need to have a decent amount of oxygen to, heal, to make sure that they're recovering properly. And so some of those contributing pathophysiologies is that upper airway collapse, that classic, soft tissue kind of, relaxing and dropping, and it can collapse. And especially when you use things like neuromuscular blocking agents, all of those things are just potentially further exacerbating the problem. Perioperative medications are also really important to pay attention to. So a lot of times when patients are getting ready to go into the ER, they're given a sedative, which can also cause some of those problems, slow that breathing rate, that respiratory rate, and can further kind of relax everything a little bit more, especially with like head positioning and stuff. But as well, you can like postoperative pain, those stress hormones and how people try to counteract those with different medications can also be a problem. And then the impaired arousal response, because those sedatives and those other medications can potentially dampen the brain's response to arousal and causing breathing to be a little bit more kind of stunted, staccatoed over time. And then the next ones here is the cardiovascular complications. And so again, like we study the pathophysiology of these things and how closely interrelated like the lungs and the heart are, how circulating oxygen works. So a lot of those same things I kind of talked about, like the stress response, right? Perioperative medications, all of those things that can affect how the body intakes oxygen can also affect how the body circulates what oxygen is available. So a lot of these things basically can cause the body to have more issues trying to get that oxygen circulating. And if there's less available because your airway's collapsing, because you have a decreased respiratory rate, all of those problems are only further exacerbated, by the heart's inability to continuously push that oxygen throughout the body, especially when it comes to like recovery. So the inflammation and endothelial dysfunction can also play a factor, just because if you have like chronically low levels of oxygen, you can actually cause inflammation and damage the blood vessels. And then obviously the hypoxemia, the hypercapnia that comes with all of these problems, just of not breathing appropriately enough, not efficiently enough, retaining too much CO2, that you see sometimes with those bigger patients, for example, in the OR. So I'm taking this presentation more as like from an anesthesiologist standpoint. And for those of you that don't know like how anesthesiologists typically do a preoperative assessment, it's usually like a pretty quick 5-10 minute. You just kind of ask like basic questions. You should already kind of know most of the questions, but the goal of what you're doing is to kind of just fill in some of those gaps and confirm some of those important pieces. However, from my experience specifically of being on anesthesia rotations, is a lot of times when a patient has known OSA, it's more of just they ask, okay, so you have OSA. Are you treated for that? Yes or no? Cool, let's move on. However, like diving into all of this, it's so much more nuanced than just like a yes or no if you're being treated or not. And so a lot of that plays into like how you screen these patients, and not only like how you screen them, but what you do with that information, right? So when you're screening patients, it's really important to not just ask like, okay, I see you have it. Are you being treated? Not yes or no. If you can get those sleep study results and or those PAP downloads, it's super important. Especially if these patients know ahead of time to be able to like bring in their machines so you can see the data like right there. Or if they have access to like sometimes their data is inputted on like the cloud or like a patient portal. It's really important to be able to see that information. It gives you like the most accurate results so you can have the most information possible. But it's important to ask all of the sleep related questions for not just the patient, but any family that they may have there, especially if they have like a spouse where they share a bed with. All of those things are really important to ask so you can kind of better understand their sleeping habits, especially like positioning wise, can be really important. Reviewing the medical records, obviously, this is something that most, if not all, physicians do just inherently. But it's important to dive into seeing if they can get some of those records related to their sleep studies or, their sleep medicine physicians, that kind of thing. And then obviously review the procedure related considerations. So take all of those things into consideration, speak with the patient about it, and try to make the best, most informed decision as possible. Most of the time, it won't like super affect like a yes or no, are you going to do the surgery or not? However, it will determine, I guess, like the course of anesthesia that you will take. Physical exam is also important. Every anesthesiologist will do a Mallampati score, just like a quick check in the throat. You can see it up there at the top, the class one, two, three, and four. And then obviously a heart and lung screen. All of those things are just very important tools that anesthesiologists use every day anyway. The OSA severity assessment is something you don't necessarily have to use, but it is an extra tool that you can use to help you determine to what extent you should be, withholding certain medications or limiting certain medications, or, what certain things you should be watching for. If you need to have like a lower threshold to do something intraoperatively, all of that stuff can be really helpful to have. And then obviously the adequacy of treatment and compliance. So this is like that big portion of not just yes or no, are you being treated? It's like you ask like, what are they using? What are the settings? How often do they use it? Is it working? Um, Obviously going and reviewing that information with the patient can be really helpful to better understand, kind of their symptoms and where they're at with their treatment. But also like, you know, seeing how some of that stuff plays into factors of like, have they had any progress since they've started being treated? Like, what symptoms do they still have? So you kind of know what to look out for. And then documentation is a huge thing that not a lot of people focus on. Is I know I get frustrated when I'm trying to chart review a patient and I know that they have like a specific type of problem. I'm looking at their chart and they don't have enough of the information that I'm looking for. And when it comes to something like, OSA, and they're going in for an operation, it might be nice just in the future. Like if I'm, an anesthesiologist 5 years from now, being able to see, okay, give me as much information of like what you found as this person's anesthesiologist at that point about their OSA, and like what did you do and was it successful? What did you have to do intraoperatively? So being really diligent in your documentation is huge. For clinical decision making, this is obviously like really a complex thing, but I'll try to boil it down as like simple as possible. But it really is for you to decide: are you going to, let this person be approved for surgery, or do they need some form of, further evaluation, whether that be send them to a sleep clinic, keep them overnight and monitor them with a PAP machine to see how they do. But it really all of those things that I said before. It's you take all of those factors that can affect that decision. Like I said, the severity of the OSA, the effectiveness of the treatment, comorbidities, level of surgical risk, all of those things. You need to have a lower threshold to defer those patients because of all of those potential risks, like that. Like I said, that 2 to 4 times increased risk. And the more comorbidities they have, the higher that risk is for complications. And then obviously sometimes you just need a sleep study. Like if someone seems to be clearly having very severe symptoms of OSA, but they haven't had a sleep study in like 10 years and they're just not utilizing their treatment, it may be a benefit to defer the surgery if you can until they get a sleep study, so you have some more information, so you're not just walking into the OR blind if you don't have to. Other things to consider is elective surgeries. Like I said, if you can defer and you feel like you need to, like awesome. Sometimes, you have the opportunity where it's like it's probably better if you wait and we have more information before, putting you under for a surgery that doesn't need to happen right now. And then obviously like for emergent and urgent surgeries, there isn't always that option, and you just kind of have to go with whatever information you have, and you just got to, stay on your toes and do the best that you can with what you got. And then this is just kind of that like decision tree, specifically on that right hand side, like the known OSA. This is just more of a visual representation of kind of like what I mentioned. And then intraoperative management. So like I said, it won't really change. Knowing someone has OSA won't really change like what you're going to do intraoperatively. It's more of just providing you more information to know like if something happens, what's going to be the easiest way for you to get, a positive outcome. And so all of these things listed as like general principles, like I said, are things that are utilized anyway every single day for every single patient. It's more of just paying a little bit closer attention to it and having that lower threshold for suspicion that like maybe intervention needs to happen. But also having a higher threshold of how much, medications you want to give. You're like, okay, let's not give too much. Let's be a little bit more conservative with what they're giving them, and then watch and stay cautious just because of how some of those, sedatives and opioids and anesthesia can just generally affect them. When it comes to those patients with like a Mallampati 3, 4, that's what like a lot of OSA patients will tend to be, especially like the ones that are a little bit more overweight. When it comes to patients with, those difficult airways, it is important to also consider, based on the fact that they have OSA and they may be a difficult airway, taking some other precautions, maybe thinking of, do I use a glide scope? Like, what's the best way of doing this to get a more efficient result as fast as possible? Because obviously when you're in the OR, you want to make sure blood is circulating, air is getting in and out properly. So the more time you wait for those things to happen, the more unnecessary risks that you have. But those intraoperative medication use, like I said, it's really important to be cautious and weary and a little bit more conservative with what sedatives and opioids you're giving, and also making sure that you have some kind of antagonist medication for those things readily available. And I don't mean like it's in your cart, and you can get it out whenever you need to, if you need to. It's like, no, if these patients have OSA, especially if they have more severe OSA, you should have that pulled and ready on your table just in case you need it, because like I said, the longer you delay, even if it's seconds, it can make a big difference in the long run. And then the capnography, obviously, like that's something anesthesiologists use just every day inherently, but again, just having a lower threshold for suspicion, keeping an extra eye on it, understanding, okay, what medications did I use? How much of it did I use? Is this an appropriate number that I'm seeing? Do I need to intervene? Yes or no? And then when it comes to post-operative care, this one was probably like the hardest part of this, trying to get information, just because this is the thing a lot of people either don't necessarily agree on, or this is kind of where a lot of those guidelines stop. They do the pre and the intraoperative care, and then they just don't really talk that much about post-operative care, which in reality, this is maybe arguably one of the more important parts, or at least as important as the other two parts, just because this is the time where now the patient is going to be, in higher pain. Medications are going to be wearing off. They're going to have to start breathing on their own. They're not going to be intubated anymore. And especially if these patients have OSA, they typically use a PAP at home, or they're not used to taking certain medications. They're laying in a very specific position, and now they don't have someone hovering over them with their monitors 24/7. So it's really important that you take all of the necessary precautions. Like, yes, you have all these general principles. And like I said, with the previous one, just have a lower threshold for suspicion for something that might be wrong, be a little bit more conservative with certain treatments that may exacerbate these problems. But it's also really important that everyone who's on the floor, like caring for these patients, that they understand that they do have to watch out for some of these things and have that lower threshold of suspicion. So, like, if they typically use a PAP machine at home, like make sure you coordinate so that they can use it with those settings in the hospital. You may have to go up a little bit, and that's fine typically. But if you're seeing a patient, now have to go up significantly in their settings, that's when you now have to start thinking, okay, is there something actually else going on? Do we need to put them in a different unit to monitor them a little closer? Obviously, if they're in a lot of pain, having to find the right balance of medications instead of just, throwing those medications at them without realizing, oh, they have OSA, this might make it worse. All of those little things matter and they all add up. But one of the biggest things that nobody talks about is like the adequate quality of sleep in the hospital. Patients typically, especially post-operatively, don't get high quality sleep. But for patients with OSA, it's really, really important that they do, because they're already at a higher risk of having low quality of sleep, not having good oxygenation while they sleep. And all those things, as you guys know, are like so essential to proper recovery from a procedure. So, making sure as many things that can be done for good sleep hygiene for these patients are also, being utilized. And then other things that, again, are typically used, just not as commonly, oxygen therapy, monitoring their ventilation status, general floor management of just keeping an extra eye and, having someone check in more regularly. are three like big things that are utilized, just not maybe to the extent that they probably should be. That could be a huge difference in recovery for these patients. And then the last one, which is another thing that is just that it like bothers me how much it's like not talked about well, is the discharge and follow-up for these patients, because like there's no real guidelines on what to do for, the discharge process, or like the decision-making process for discharge specifically for patients with OSA. And there's definitely no real guidelines when it comes to how follow-up is scheduled, whether it needs to be with a family doctor, whether it needs to be with the surgeon, or whether it needs to be specifically with a sleep doctor. So this is like just generally what I found, is what at least some people could agree on, is that you should delay discharge until there is like for sure no one can be maintained without any kind of support. Obviously, that does not account for like their nighttime PAP. But also having limited guidance on safety discharge timelines and protocols for these patients makes it really hard. So it's really coming down to like using best judgment on like when's the best time to do it. Typically, it won't really affect the timeline compared to regular patients, as long as they are, oxygenating well, and, they're not having like significantly more apneic events while they sleep. And then it's typically roughly the same timeline. Another one is like to advise the consistent use of the PAP therapy. A lot of times patients will be really uncomfortable after they have surgery, and that's when they don't want to use those PAP machines, especially because like they're in the hospital. They use it kind of as the excuse, like to not be hooked up to all their crap that they do at home. But it is really important that, especially, post operatively, that they are using those things. And then limiting opioid use post discharge. That one like really sucks for a lot of patients, because they obviously want the medications that aren't going to make them in pain anymore, but in order to make them healthier, I guess, like long term, and reduce their risk while they're in the hospital, you kind of have to like find that right balance. And but it's important to like work with them on it, so you can limit those properly, especially like when they leave the hospital, because a lot of times, and I'll talk about this in a second, but a lot of times the hospitals and doctors will just like send patients out into the world with like a bunch of opioids and medications and stuff, and especially for these patients, that can be really damaging. And then obviously, advise follow-up care with their sleep medicine provider. If, they use a PAP machine, they have a sleep doctor. It's always really important to say that, like, they are the experts on this. When it comes to this kind of stuff, like, it's good to check in with them. And that's kind of like what I'll talk about in a second. So the role of sleep medicine, in regards to these patients, is like, though all of those medications that I just mentioned, like I said, doctors just kind of throw them at these patients. They don't really give them a lot of information, and they don't really like consider how OSA can factor into these medications, and they send them out into the world. So as like a sleep medicine doctor, it is important to like educate these patients and kind of explain, see like, okay, well, why did they give you this? Do you understand like how this can potentially affect you? But so it's important to have those patients be able to like empower them to ask those questions to their doctors when they know they're going in for a surgery, because it then helps the provider, it should help the provider, who's, prescribing these medications, to kind of take these things into more consideration, using those like opioid sparing techniques, and potentially avoid causing more problems. But that thing that I mentioned in the very beginning, that REM rebound, is this like, it's a known problem, but like there's being more research about it. I won't like dive too much into it. I like went down a whole rabbit hole about this, but basically, when a patient like doesn't get good sleep in a hospital, especially like post-op, and especially patients with OSA, because they're at higher risk of this. On certain nights of them staying in the hospital, they will have like really poor quality of sleep, and then really good quality of sleep when they get home, and then they kind of rebound back to having really poor quality of sleep, more apneic events, and the bullet points below are just like some, things that patients can experience, or things that cause it. Like I said, I nerded out about this. I went down like a whole rabbit hole, but I won't bore you guys with it. If you're interested, you could look it up. So like I said, patient education is huge. It's really important to not only make sure that they understand things related to their diagnosis, and like, how it may affect them, but it's also really important to encourage them to ask their providers questions. If they're going to go like for an elective surgery, and that ahead of time, encourage them to ask like, what medications am I going to be discharged on? How will this affect my OSA? I have this PAP device with these settings. Is that something that may be a problem in the OR? it's all really good stuff to make sure that they feel empowered to ask and have that knowledge of going into and coming out of their operations. Next is documentation. Like I said, huge. As a sleep provider, it's really important to be able to obviously document well. And hopefully, you can't force anyone to, but hopefully the other providers, like the surgeons and the anesthesiologists, are pulling those records and reading those thoroughly and kind of understanding the full scope of the patient. And then lastly, just the post-op follow-up. It's never a bad thing to have the sleep doctor speak with the patient after surgery, and discuss like how do they feel, how do they think it went, how are they doing, how are they sleeping now, post surgery, what medications are they on, all that stuff I kind of talked about. It never hurts. Thank you guys. That was it. I just have some references here.
And does anyone have any questions about the presentation at all? I can go first. This is like more selfish because I'm going into emergency medicine. So like from an emergency medicine standpoint, you get like a trauma patient that you know is going into surgery and stuff. Um, are there like things that you saw like at least on your rotation or anything like that that they could have kept in mind prior to them just going straight to the OR for like on your guys' behalf if it's like an OSA patient, that made it a little bit more difficult like post-operatively and everything to manage?
So I was all outpatient, but I know Monsi did like, certain days that she would be in the hospital. I don't know if she can answer that better.
Yeah, so sleep is primarily outpatient. However, there has been
Yeah,
a recent influx of trying to get sleep doctors more so in the hospital, specifically for either like inpatient consults in the ICU or like a step down unit or for like trauma related purposes. I will say that if you have a high degree of suspicion for OSA, even if the patient hasn't been diagnosed, you can set up someone with CPAP while they're in the hospital, like post-op, and then they can
okay,
just get a sleep study afterwards. Ideally, you would want it done before in like a stepwise manner.
right,
That is possible, and I would definitely recommend for all of you guys that are either going into like EM, anesthesia, surgery, or like some form of like an inpatient hospital field to understand what the protocol and workflow is that your health system has in kind of managing these patients. Kind of like what Zach was saying, there's no definitive guidelines for a lot of
right,
these things. You kind of have to take it on a case by case basis. But there are certain requirements and certain protocols that like health systems need from sleep doctors in order to either start a patient on a CPAP, keep a patient on a CPAP post-op, what settings, what things do you need written down in like a note in order to continue to take care of this patient. So I would definitely familiarize yourself with that because based off what your hospital needs, the sleep doctor can write their notes accordingly, which is what I have done
yeah.
here.
Yeah, absolutely. I feel like when I was seeing patients, I would come in, they wouldn't really necessarily know like their settings. They just knew their CPAP worked for them and whatnot. And it was like difficult to get that for them, especially if their airway is like um under consideration for like getting one and whatnot too. But okay, thank you so much and enjoy.
Yeah, great presentation. Really loved it. I'm also going to be a little bit biased and go towards my field in terms of pediatrics. And I just wanted to know, like, how, if in a pediatric patient, how would that affect either like management or like airway, how to manage their airways if someone comes in and they maybe like more on the obese side and knowing if they have OSA in terms of surgery, like in terms of pediatric, how would that change or be different?
I can take this one. I don't think Zach saw as many peds patients, but for pediatric patients, especially if they're on a CPAP post-op, 100% you're going to want them to be placed on their CPAP with their home settings. You can have a sleep doctor kind of document the exact settings, the exact pressures that they're on, the type of mask that they're using. If they're going to be very sedated and groggy post-op, they might not be comfortable or have the ability to put their own mask on. So you do have to kind of consider, well, should I change masks? That's a big thing. Or, do I want to add more straps on to make sure there's a good seal and there's adequate treatment being given? And then I will say for the pediatric patients who undergo major surgeries post-op, they do require a higher level of ventilatory monitoring afterwards. So maybe they're spending an extra night or two in the PICU, or maybe if there's like a step down unit, they'll do additional day or two there just to make sure everything's okay. Like Zach said, you don't want to discharge somebody without making sure that their oxygenation, their blood pressure, things like that are okay. And in kids, we want to be like perfectly sure with a very close sleep medicine follow-up directly afterwards. The PEDS patients that we've seen post-op, they usually write in their discharge instructions, follow up with your sleep doctor within a week, et cetera, et cetera. So there's usually a higher degree of follow-up with those patients than the adults, but that's kind of how you want to go about doing it.
Thank you so much.
I won't keep you too long. I just thank you, Dr. Mancy, for coming today. And thank you, Zach, so much for this excellent presentation. It was incredibly interesting.
Thank you
Thank
so
you,
much.
guys. Thank you, Monse.
Yeah, of course. Thank you so much for having me. Great work, Zach.
I hope you have a great day, Dr. Mancy. Thank you. All right. And thank you again, Zach. That was awesome. I'm just going to stop recording this.